Hi, everybody. Good evening. We're going to give it just a moment to let everybody make their way in. Good evening, Dr. Friedman. How are you tonight?
Hey, Jen, thank you so much for inviting me to be here. Looking forward to it.
We're excited to have you, and it looks like there are tons of people making their way. So, to be very respectful of everyone's time, because I know we have a lot of great information that we have to get through, I'm going to get started. So, welcome, welcome, welcome to tonight's Wu University event, The Foundations of Dry Eye Management. And I'm joined tonight by Dr. Kimberly Friedman.
So, hey there, everybody. Thank you for joining in. I can't believe how many participants we have already.
Still coming. So, and you can advance. And I'm your host, Dr. Jennifer Stewart. It's my great pleasure tonight to be joined by Dr. Kimberly Friedman. She's a founding partner of Morristown Eye Associates, a large private group optometric practice in New Jersey, and she's the director of the Dry Eye Clinic at Morristown Eye. She's a past president of the New Jersey Society of Optometric Physicians, a fellow in the American Academy of Optometry, a diplomate of the American Board of Optometry, and a past clinical director for the New Jersey and National Special Olympics Opening Eyes program. She currently serves as a vice president of education and scientific affairs with the PRN Vision Group. She also serves on the national advisory board of PECA Healthy Eyes Advantage, previously on the advisory board of Women in Optometry magazine, and has appeared in numerous television segments and print media throughout the United States, including The Rachel Ray Show. That's very cool. I didn't know that.
Here's really
And multiple Philadelphia area morning programs. Dr. Friedman has received many awards, including OD of the Year and Young OD of the Year awards, VSP's People First Award, and the Special Olympics National Recognition Award. She lectures nationally and internationally and writes recurring columns for various eye care related publications. Welcome, Dr. Friedman. We can't wait to learn from you. With that, I'm going to turn it over to you, and I'll see you at the end for the Q&A.
terrific. Thank you so much. And I clearly would not qualify for the Young OD of the Year award anymore. That's for sure. Thank you all so much for joining. My financial disclosures are on the screen. All financial relationships have been mitigated according to COPE's rules and regulations. The financial relationship that is the most relevant is that I am the vice president of the PRN Vision Group. However, when I am delivering COPE lectures, certainly I go to great extents to make sure that we're following all COPE regulations and try to present peer-reviewed published journal publications with as little commercial bias as we could possibly have in any of these types of lectures. So again, thanks again for joining us. Tonight's lecture is going to focus on the first steps of incorporating dry eye management into your practice. And while it might not be maybe as sexy or as new of a topic as the more advanced dry eye procedures or emerging technology or new drugs that we have in the pipeline, I'm hoping that tonight's lecture will still provide really useful information for everybody. So if you're just starting to incorporate dry eye into your office, and maybe if you think you can't really incorporate dry eye into your office, well, then tonight's lecture is perfect for you. But even if you already have a thriving dry eye practice, I hope that this will serve as a useful reminder of some of the basics. These basics are really important for all of us to remember, and maybe there'll be a few tips thrown in here that we can incorporate into all of our practices. Please make sure that you submit any questions because at the end, hopefully we'll have some time for just some frank conversation about some tips and tricks that we can all share with each other. Now, obviously, I don't need to tell you that dry eye is ubiquitous, right? TFOS News reported that 344 million people in the world suffer with dry eye disease. And it's clear that dry eye is one of the more common conditions that we see in our practices. As optometrists, we're really on the front line of managing this disease. But as I travel around the United States lecturing, I meet with a lot of colleagues, and I find that there's almost like a bifurcation in our profession when it comes to dry eye management. There are optometrists that have spent a great deal of time and effort and investment in expensive equipment to develop dry eye clinics or subspecialties. And then there's optometrists that generally don't emphasize the diagnosis and management of dry eye in their practice. And as I began to talk to some of those colleagues who either don't enjoy or avoid managing dry eye, I began to hear a very common theme. And it became apparent to me that these people that were not practicing dry eye or promoting dry eye in their office, they didn't feel like for some reason that they were qualified to manage dry eye without the expensive equipment, without thermal pulsation or IPLs or radio frequency equipment. They just felt like that was something that they weren't somehow qualified to manage dry eye patients. And the reality is that there's a lot of us that can't have that expensive equipment. Maybe financially it's just not feasible. Maybe it's a physical space limitation. Maybe you're an employed OD and you really don't have the authority to bring that kind of equipment in your office. And there was one particular doctor that I spoke to, and I'm never going to forget this. He said that treating dry eye disease was, quote, demoralizing to him because he felt inadequate in treating the patients because he didn't have the fancy equipment. So as I started to think about this more, I realized that this bifurcation in our profession is really somewhat unique with dry eye. We don't feel inadequate to treat glaucoma, even though we have to refer some of the more advanced cases out for advanced procedures. We don't feel inadequate in managing cataract patients because we ultimately have to send them out for surgery. But with dry eye, somehow we feel inadequate to manage it unless we have the full armamentarium of equipment in our office. Whether you're an employed OD who has no say in the equipment available in your office, or whether you practice in a setting that really emphasizes refractive technology, or whether you practice in a medical-based practice, it really doesn't matter. We all have the ability to manage dry eye, even if we don't have a dry eye clinic per se. We can all comfortably, within our profession, allow ourselves to treat the vast majority of our dry eye patients, even if we don't have the fancy equipment. So where do we start? Well, first, we have to start with the understanding that foundational dry eye management is available to each and every one of us. All you need is your slit lamp, your brain, and your ears. And as you manage dry eye that is already in your current patient base, you will not only improve your patient outcomes and build patient loyalty, but you'll also build a pretty substantial additional revenue stream in your office, and you will solidify your standing to the patients as the primary eye care provider for their refractive and their medical needs. So how do we start out? Well, fortunately, we have roadmaps to follow. There are evidence-based treatment algorithms that have been developed by multiple organizations that are available to guide us. We don't have to go and research all the dry eye studies ourselves. These algorithms help us spend our time as clinicians while these think tanks and researchers comb through the literature to develop the best practices for us to use. So we combine these algorithms with our clinical experience, and we can end up being able to treat the vast majority of our dry eye patients in our office. So let's take a look at what is probably the most often referenced roadmap for the treatment of dry eye and examine what it teaches us. We hear a lot about TFOS-DUES-2, but what exactly is TFOS-DUES-2? Well, the Tear Film and Ocular Surface Society consists of 150 clinical and basic research experts from around the world. And they utilized an evidence-based approach to achieve global consensus on algorithms for the treatment and management of dry eye disease. Their first report came out in 2007, and that report was really instrumental in leading to the inclusion of dry eye as a classified disease. It led to an explosion in research and product development in dry eye management, and it led to ICD-9 and 10 diagnosis codes, which allowed us to actually be reimbursed for dry eye management. And then in 2017, TFOS-DUES-2 was published. Now that followed a 2.5-year investigation, and the results of their research has formed the basis of that updated definition of dry eye that we all hear so often about, the multifactorial definition of dry eye disease. And the contemporary classification system of dry eye disease and the comprehensive treatment algorithm that we use now came out of this TFOS-DUES-2 study. It emphasized the restoring of homeostasis on the ocular surface. Now, to give you a little bit of update, in 2023, the Tear Film and Ocular Surface Society published a lifestyle report, which focused on the recommendations surrounding contact lenses, cosmetics, digital environment, elective medications and procedures, environmental concerns, lifestyle challenges, nutrition, and societal challenges as well. If you haven't had the opportunity to, even if you don't want to dive into the 100-page report, you can even read some of the summaries online. Just look up TFOS-DO's lifestyle report. A lot of great information in there, again, in this evidence-based clinical research approach. And finally, 2024, they just announced the beginning of phase 3, which is going to be TFOS-DO's 3. In their announcement, what they stated was, since the publication of TFOS-DO's 2, there have been more than 8,000 peer-reviewed articles published about dry eye disease. So given the extraordinary amount of research over the past 7 years, they decided to update TFOS-DO's 2 and focus on the new and significantly advances in the diagnosis, treatment, and classification of dry eye disease. So I think we're going to start to see even more research in this area becoming available to us very shortly. But for now, our most current treatment algorithm from the TFOS group is shown here. And it's the TFOS-DO's treatment algorithm, and it's broken down into steps or stages. Steps and stages 1 through 4. And since our lecture today is talking about foundational therapy of dry eye disease, that which every single one of us on this meeting tonight can do without any fancy equipment or extra staffing, we're going to focus on step 1. And it's my hope that even if you have an advanced dry eye clinic, you'll still walk away with some tips and pearls that can be applied to your practice, because I know I always pick up extra nuggets of information that I may have forgotten along the way when I go back and look at the fundamentals. So what does step 1 TFOS-DO's therapy involve? Education, modification of local environment, dietary modifications or oral supplementation, systemic and topical medication analysis, ocular lubrication, lid hygiene, and compresses. The basics. So let's take a look at each one of them. We're going to start with education. Now, the exact words that were used by TFOS-DO's 2 were education regarding the condition, its management, treatment, and prognosis. And I can tell you that after nearly 33 years of patient care, I think that the education piece is probably the most important thing that we do in our exam rooms. I used to think that I was the only person in my family that was not a teacher. Literally every single person in my family is a teacher or works in the school system. But then I realized I was one of them too. So much of what we do in the exam room is education. Gone are the days when we are spending most of our time in data collection. Our machines and technicians do a fantastic job of collecting the data. Our job is to interpret that data, develop a plan, and then teach that plan to the patients in a concise and effective way so that we gain the patient's buy-in and gain the patient's compliance. We could be the best data collectors in the world. We could have the most effective treatment plans ever developed. But if we don't educate well, it's all going to fall apart. At the heart of this all, we have to be good teachers. And when I educate patients about dry eye, the first thing I do is tell them that dry eye is an inflammatory condition. And I joke around that it's like arthritis of the eyeball. But that little joke helps people understand that dry eye is not a feeling of dryness, that it's truly a progressive disease that requires management. I educate them that just like arthritis, this condition will progress, and it will ultimately lead to greater discomfort, greater blurred vision, and a reduction in the cosmetic appearance of the eye as well. Because if I can't get them on reduced vision or reduced comfort, I can get them on reduced cosmetic appearance of their eyes. So patients often won't invest in a dry eye treatment if they think it's just about a feeling of dryness. So make sure that they know that it's really an inflammatory condition as part of your educational protocol. Now, we have to explain that we need to treat beyond just the sensation of dryness for another reason as well, because we know that many of our dry eye patients are asymptomatic. By definition, there's a neurotrophic component to what we're dealing with here, and they're not going to feel things the way we would think that they would feel them. We've all seen those patients where their signs and symptoms are way out of proportion. Either the symptoms are so much worse than the signs that we're seeing, or vice versa. The signs look so bad and the patient says, yeah, I feel fine. So we really have to educate about the blur, the inflammation, the redness, and all the other signs and symptoms in order to provide the necessary disease state education to then ensure the patient compliance. Now, the next thing in the TFOS DUES 2 stage 1 therapy, environmental factors. And I think we tend to overlook this a lot. My office is in New Jersey, and I'm booked solid October through April in the dry eye clinic, but I get slower in the summer months. The dry, dehumidified air of the winter really exacerbates dry eye to a tremendous degree, probably more than we even consider. And what about makeup? Patients who are using eyelash growth serums or draw lines of eyeliner over the top of their meibomian glands are certainly a greater risk for ocular surface disease. But why are we afraid to talk to them about it? We see patients with these 1-inch long lash extensions under the slit lamp, and we say nothing. We see eyeliner over the inner rim of the lid, literally painted over top of the orifices of the meibomian glands, and we ignore it. I saw literally today an article that Selena McGee wrote that I thought was so great. And what she said was, we have to start to have the conversations with our patients that we are already having in our head to ourselves. And I'm grossly over simplifying what she said. Her article was so well written. But essentially, to paraphrase, we should be saying out loud what we're thinking to ourselves. We look and we see all that crustiness to the lashes. We see the eyeliner caked over top of the meibomian glands. And in our head, we're saying, oh, that's gross, ick, disgusting. But we don't say it out loud. We don't actually tell the patient. Now, maybe we could use better words than ick and disgusting, but the reality is we should be educating our patients about what they're doing to their ocular surface health when they are utilizing these type of makeup techniques. Certainly, we also know the consequences of overexposure to wind and pollutants. These are things that we need to talk about with our patients. Something as simple as using a room humidifier in the winter next to the bed, or turning off the ceiling fan, or making the blowers in the car not point towards your face. And we immediately think of drugs and procedures, but sometimes this simple stuff like making modifications in the environment can really make a difference for our patients. And then the next pillar in the TFOS DUES algorithm can seem obvious again, but sometimes we are causing dry eye with the topical and systemic medications that we're using with our patients. Just think about the glaucoma patients alone. The topical drops that we use for glaucoma cause dry eye. Show me a glaucoma patient, I'll show you a dry eye patient. Should we consider, when we have a glaucoma patient who has dry eye, would we be better off considering a surgical option or a laser option as first-line glaucoma treatment instead of drops that by definition will exacerbate the dry eye? And one last thing to keep in mind, my practice is largely limited to rheumatology patients. And when you see that 20 to 40-year-old with that dry eye that is just way out of proportion with his or her age, it doesn't hurt to ask about other inflammatory conditions they might be experiencing. Do you have any issues with joint pain, arthritis, colitis, skin issues? You might help a person get to a rheumatologist years before they would otherwise get there. And that can make a huge difference in their quality of life. The average amount of time between when a patient starts with symptoms and they actually get to a rheumatologist is 7 years. We are in a unique position that we can collapse that time frame. And if we just start to notice that this dry eye or ocular surface inflammation combined with some of these systemic itises that we might not ask about, or recurrent psoriasis or eczema or dermatitises that we might not be asking about, might really make a huge difference in that patient receiving a diagnosis of Sjogren's or psoriatic arthritis or rheumatoid arthritis or lupus, simply because you asked the questions and sent them to a rheumatologist for a workup. So it's really important that we think systemically when we're seeing these dry eye patients as well. Now, the next stage in TFOS DOs talks about ocular lubricants. And the truth is, in the United States, our FDA approval process for artificial tears is a bit out of date. For example, when I'm traveling in Canada, hyaluronic acid is the #1 ingredient that they have in almost all of their artificial tears that are available for their patients. And yet in the United States, hyaluronic acid is still not approved as an artificial tear ingredient in the US. Now, that doesn't mean that we can't get tears with hyaluronic acid, but it has to be listed as an other ingredient, not the active ingredient. And these types of kind of outdated monograph that we have for artificial tears can limit some of the options that the manufacturers have in presenting artificial tears in the United States, limitations that are not there in other countries. But there are still great artificial tears available in your arsenal to use as complementary therapy to the other foundational therapies for dry eye. Now, I want to share with you some practical advice from my office about artificial tears, though. By the time the patient has come to see you, they have probably already consulted Dr. Google, they've talked to their friends, they've tried all the over-the-counter remedies that they could find. And if all you do is give them an over-the-counter artificial tear and say, hey, let me know if any of these work and, get back to me if you're still having symptoms, you're probably going to lose the trust of that patient forever. They are coming to you for something beyond what they can do for themselves. And the expectation is that just giving them something that they can access at the drugstore themselves means it was a wasted appointment for them and they have to start all over somewhere else. I'm not saying that artificial tears are not a good adjunctive therapy for our patients, but it should not be the only thing that we're giving to our patients. And that still persists very largely in a lot of ophthalmology offices and some optometry offices today. Also, I have found that MIBO has been a game changer for me in my office. Now, honestly, I'm saying this, I didn't even know that Bausch & Lomb was sponsoring tonight's lecture, okay? But this is truly from my experience. It has largely eliminated or at least reduced the need for patients to be reaching for artificial tears frequently. When I prescribe MIBO, I often tell patients, anytime you would have reached for the artificial tear, reach for the MIBO instead, up to 4 times a day. Okay, the MIBO really works very well as kind of a substitution for the regular use of over-the-counter artificial tears. It's been working quite well. Obviously, every patient is different. It's not going to work 100% of the time, but I've been really impressed how it has reduced the need for over-the-counter artificial tears in many of my patients. And that was an unsolicited commercial for MIBO. I didn't even know they were a sponsor tonight. So now let's look at TFOS-DO's recommendation for the dietary modifications, including oral essential fatty acid supplementation. And we're going to spend a little bit more extra time on this one because it can be quite confusing. And the truth is we don't really get a great education on nutrition back in our school years. The essential fatty acids are omega-3s and omega-6s. And essential fatty acids are called essential because we cannot manufacture or store them. So that means we must consume them regularly. Now, in the typical American diet, we are quite deficient in omega-3 fatty acids, but we get plenty of omega-6 fatty acids. Recent data indicates that the half-life of omega-3 fatty acids in the body is about 2 days. So this is not something that we can just take every once in a while. If we have a fish dinner once a week, that's not going to do it for us. We have to keep our levels in the healthy range. And that means that we really do need to consume omega-3s on a regular basis. So let's take some time breaking down the different types of essential fatty acids and how they're deficient in the diet, how we can get more in the diet as it conforms to the TFOS-DO's 2 recommendations. So let's start with a quick review of omega-3 fatty acids and how they impact ocular health. Omega-3s are essentially doing 3 things for our eyes. Easy to remember. Omega-3s, they do 3 things. First, they actually directly affect the composition and quality of the meibum. Meibum consists largely of omega-3 fatty acids. And omega-3 fatty acids at body temperature are the consistency of olive oil. So when we have a lot of omega-3 fatty acids in the meibum, it allows for the meibum to flow on the blink as it should. However, insufficient omega-3 intake will result in the body making a substitution. It's not going to leave the meibomian glands empty. And if you don't get enough threes in your diet, the body will substitute omega-6s. Omega-6s at body temperature are the consistency of like butter or margarine or lard. It's going to result in the clogged meibomian glands with that toothpaste-like meibum that we see. So whenever you see that thickened toothpaste-like meibum, by definition, you are looking at a person with a deficiency in omega-3 intake or an excess in omega-6 intake or some combination thereof. So that's the first thing omega-3s do, meibum quality and composition. The second thing omega-3s do, they mediate the anti-inflammatory pathways in the body and counteract the pro-inflammatory pathways that are omega-6 mediated. This can help to prevent chronic inflammation, both locally for the eye, as well as systemically overall. And the third thing that omega-3s do is something that I think optometrists and ophthalmologists are a little bit less aware of. And that is that they form the physical structure of the cell membranes in our body. It's represented by the purple little circles in this diagram. In fact, more than 50% of the structures of the cell membranes and the photoreceptors in the retina are comprised of omega-3 fatty acids. Omega-3s facilitate cell communication and nutrient exchange in between the cells. So maintaining cell health and playing a crucial role in retinal structure and function is omega-3 fatty acids. So I think we tend to think of omega-3s as just a dry eye thing, but the reality is omega-3s, because they form these cell membranes of our body and are responsible for communication between cells, they're crucially important in the retina and the brain as well. So there are lots of peer-reviewed published data supporting the use of omega-3 fatty acids for dry eye management. But there are definitely some nuances to what form and dose of omega-3s are effective. And it can be very confusing because I can show you studies that say omega-3s are the best things since sliced bread. And I can also show you studies that say that they don't work at all. And that has led to a lot of confusion with both practitioners and patients. So I'm hoping I can clear some of that up a little bit tonight. There are a lot of studies on omega-3 fatty acid consumption and systemic health. So from their anti-inflammatory benefits, cardiovascular benefits, brain health benefits, it seems more and more studies are published almost every week. If you have an interest in learning more about omega fatty acids, there's an organization called the Fatty Acid Research Institute, and they publish updates on omega research regularly. They also just update their website with new data showing that approximately 8% of all of the omegas on our cell membranes should be omega-3s in order to have kind of that healthy environment that we're looking for systemically. This slide shows just a few items that were recently published in literature, showing a 49% reduced risk in Alzheimer's in people over 50 if they had a higher intake of omega-3s, and a 90% reduced risk of cardiac arrest. And these aren't in like kind of weird fringe nutritional studies. Like these are legitimate NIH well-respected studies. The Alzheimer data comes from Framingham data, which is the largest running cohort study running in the United States, sponsored by the NIH since 1948. So it's really legitimate data out there. So given that omega-3s are so important for ocular health and systemic health, can we get enough of these in our diet? Well, it's a little tricky. If we're talking about omega-6s, yes, we get plenty of those in our diet. But with omega-3s, it's tough because omega-3s generally come from seafood. And even the seafood that we eat today doesn't really come from wild-caught seafood anymore. It's generally farm-raised. And farm-raised seafood are fed corns and grains to fatten them up and get them to market. So the omega-3 content in farm-raised seafood isn't necessarily that of wild-caught seafood. And that's why the omega-3 supplement industry was born, right? It really became one of the top supplements within the United States pretty quickly. If we look at data from 2023, the number one supplement taken in the consumer lab survey was vitamin D. The number two is actually magnesium. That surprised me. Number three was omega-3 fatty acids, and multivitamins came in fifth. So the third most popular supplement taken by our patients is omega-3s. And it's important that we understand omega-3 supplements so we can advise our patients more accurately. Now, let's start to look at some of the published literature that applies to dry eye and omega-3s. In 2005, an analysis of the Women's Health Study with over 32,000 participants revealed that the lowest incidence of dry eye was found in those with the highest intake of omega-3s, and the highest incidence of dry eye was found in those with the lowest intake of omega-3s. But the early studies on dry eye and omega-3s were always looking at dietary intake, not supplements. So we also have to look at supplement studies to see if the omega-3 dry eye connection would still hold up. So in 2011, Greg Smith, a Wills Eye surgeon, presented this study at the Cornea Society, where he did meibum expression and analyzed its content, and then supplemented with a re-esterified triglyceride form omega-3 fatty acid supplement. And then, after 8 weeks, re-expressed the meibum and analyzed it. What he found was after 8 weeks, the EPA and DHA from the supplement was found in the meibum. That proved that the supplement in the triglyceride form absorbed through the GI system enough, traveled through the bloodstream, and got to the meibomian glands enough to physically change the composition of the meibum. In addition, the supplemented group hit statistical significance for improvement in breakup time, staining, and osmolarity, in addition to a subjective 70% asymptomatic rate. 70% asymptomatic rate with just monotherapy of omega-3 fatty acids is pretty impressive. I know Restasis, Xiidra, Cequa is probably not giving me a 70% asymptomatic rate alone. The next study I want to look at is a blind randomized placebo-controlled multi-center study. And in this study, there were two groups, one receiving a little over 2,000 milligrams of the re-esterified triglyceride form omega-3 supplement, and one receiving the placebo. And if we look at the results, we see that the tear osmolarity reduced by nearly 20 milliosmoles in the supplemented group. The MMP9 positivity reduced by 68% in the omega-3 group. The OSDI symptom scores also had a statistically significant reduction. And the one that I like the most, the tear breakup time improved by 3.5 seconds. I should say nearly 3.5 seconds, 3.47 seconds. And that could really explain the improvement in the OSDI symptom scores as well. All of these results hit statistical significance with very impressive p-values. We know that 0.05 is statistically significant, and most of our drug studies, the results just eke out 0.05 statistical significance. But with the omega-3 studies, the statistical significance are incredibly deep p-values of like 0.002, much more statistically significant than many of the drugs that we have available to us. And I love that 3.5 second tear breakup time metric, because to me, 3.5 second tear breakup time improvement is really the difference between a patient being comfortable in contacts or not, or a patient being eligible for LASIK or a premium IOL or not, or a patient sitting in your chair constantly for RX checks because they're not getting stability with their tear film and therefore fluctuating vision. And one other thing that we should consider when we're talking about omega-3 supplementation is the dry eye that we find in our pre-op cataract and refractive surgery patients. We know how prevalent dry eye is in our cataract surgery population. In 2017, a largely reported on study by Trattler revealed that nearly 90% of the patients reporting for cataract surgery had dry eye, yet only 20% were diagnosed and treated prior to presentation. And obviously, if we don't address dry eye before surgical intervention, we could end up with unhappy patients and refractive surprises. This was another study on preoperative cataract surgery patients. And what this study revealed is that those patients that had hyperosmolarity were also those patients that had inconsistent and inaccurate preoperative biometry measurements, up to 1 diopter off in the refractive error that was measured. Obviously, addressing dry eye in these preoperative patients is critically important to reduce the chances for those refractive surprises, especially if someone's paying for a premium IOL. And this is one more final study we'll cover about the omega-3s, published in British Medical Journal in 2020. These were on post-op cataract surgery patients that developed dry eye post-operatively. One group got artificial tears alone, one group got artificial tears with omega-3 supplementation. And the group that got the omega-3 in addition to the tears had statistically significant results in staining, MMP9 positivity reduction, and subjective results. So omega-3s were involved in postoperative healing improvement as well when addressing dry eye. But I understand that for every study that says omega-3s are the best thing for dry eye, there's another study saying it doesn't work, and it can be confusing. So let's talk about why it's confusing. I'm going to cut to the chase here and just show you. On the left, we have the study that I just talked about, where the omega-3 hit the statistical significance for all the signs and symptoms of dry eye in a blind, randomized, multi-center, placebo-controlled study. But on the right, this is the VITAL trial analysis, which used Leveza, which is an over-the-counter, a prescription omega-3 fatty acid drug. It's in an ethyl ester form. And what the VITAL analysis showed was that the Leveza supplement did not work to reduce the incidence of dry eye. But what this study really showed was that the poorly absorbed ethyl ester form of the omega-3 fatty acid supplement at the 1 gram a day dose did not work for dry eye. And we've known that for a really long time. What this study is showing us is that the form and the type of the omega-3 supplementation and the dose really matters when we're dealing with dry eye. In this particular VITAL trial, they were given 1 gram of an ethyl ester form, Leveza, and the blood index level in those participants only rose to 4% of the omega-3 index. It was 4.1%. After 1 year of taking Leveza. In contrast, if we look at a 2,000 milligram omega-3 fatty acid supplement in the triglyceride form, it gets to 8% in 3 months. 8% in 3 months, 4% in 1 year. If we're getting a subtherapeutic level of omega-3 fatty acids due to dose or poor absorption in the ethyl ester form, it's no wonder that it's not working for dry eye. The bioavailability is simply not the same between a triglyceride form and an ethyl ester form. And you have to be very careful with the headlines that paint all omega-3 supplements with the same broad brush. We really have to dig into the study, and what we'll find is that most of the studies that say omega-3s don't work are in the ethyl ester form or in extremely low doses. And the studies that show that the omega-3s do work for dry eye are in the triglyceride form in 2,000 milligrams or more. After the VITAL trial came out and the DREAM trial came out and said that omega-3s weren't working for dry eye, this paper was published in Cornea in 2019. It's the largest meta-analysis done to date on dry eye and omega-3 supplementation. It included 17 randomized clinical trials with over 3,300 patients. It included the DREAM trial, the Cornea study that I've already mentioned, and 15 other studies. And the meta-analysis demonstrated clear evidence that omega-3 supplementation significantly improved the signs and symptoms of patients with dry eye. That's why it was included in the TFOS DUES 2 analysis, just like their algorithm says. But I do understand that confusion can be out there because not all omega-3 supplements are the same. So what do we need to look for in omega-3 supplements? First, the type of omega-3 should be EPA and DHA. That is the seafood based. Sometimes you will also see DPA on the shelf. DPA is an intermediary step in the conversion between EPA and DHA. Pretty much all omega-3 supplements that have EPA and DHA will have some DPA in there as well. It's just that for marketing reasons, some people put it on the label and some people don't. But EPA and DHA are the marine-based fish, shellfish, and algae form that we should see in our supplements. You might see DPA on there too, and that's fine too. Now, if you see ALA, that's the vegetable source of omega-3s, commonly found in supplements from flaxseed oil. Unfortunately, ALA is no longer efficiently converted down the omega-3 pathway because of the unavailability of an enzyme, a 6-delta desaturase enzyme that's being largely used up in our body on the omega-6 pathway. Therefore, multiple studies have shown us that ALA is really a poor source of omega-3s at this point. So if you want a vegetarian source of omega-3s, you still have to get EPA and DHA and not ALA, and the way to do that is with algae. So with algae, you can get a vegetarian omega-3 that would be good for our patients. Otherwise, any seafood-based EPA and DHA would be good for our patients. And again, although we're mentioning these supplements for ocular health, we can certainly explain to patients that increasing your omega-3 intake is linked to a lower risk of overall mortality and other health metrics. So we know that we need to look for EPA and DHA. We also need to be aware of the different biochemical forms. Most omega-3 supplements are in the less absorbable ethyl ester form. That is the form that is made when you harvest fish oil and clean and concentrate it into a supplement. That form tends to sit in the stomach and give you fish burps and queasy indigestion feeling because only about 1/3 of it actually absorbs into the bloodstream. Your better quality omega-3 fatty acid supplement manufacturers will take that cleaned and concentrated ethyl ester form and convert it back into a triglyceride form. The triglyceride form is what is found in fish. It is 61% more bioavailable than the ethyl ester form. These supplements have about an 85 to 90% absorption rate, especially when taken with food. But that extra processing step to convert it from an ethyl ester to a triglyceride costs a lot of money. And that's what the difference is between the $25 bottle of omega-3s that you see on the shelf and the $50 bottle of omega-3s that you see on the shelf. That extra processing accounts for the extra cost, but it makes a world of difference in terms of the effectiveness of the supplement for our patients. So when it comes to TFOS-DO's 2 recommendation on dietary modification and supplementation, the upshot is that we want to have a little over 2,000 milligrams a day of EPA and DHA in the triglyceride form. We want to use a supplement that's been clinically proven in blind randomized placebo-controlled studies. And we should also counsel our patients on a diet that's rich in colorful vegetables and fruits and seafood, that basically like the Mediterranean type diet. That's what's going to be ideal for our dry eye patients and what conforms to the TFOS-DO's recommendation for supplements and dietary modifications. Now, going back to TFOS-DO's, we're now on the last recommendation in their dry eye algorithm, and that is lid hygiene and warm compresses. And just like TFOS-DO's opened our eyes to the multifactorial nature of dry eye disease, the Ocean group did the same thing with meibomian gland dysfunction. You've probably seen this circular image at some point showing how all the causes of meibomian gland dysfunction feed on each other and exacerbate the condition. And from this publication, they laid out an acronym to help you remember all these causes. They called it BESTO, and that's B for bugs and bacteria. So whether it's bacteria or Demodex mites that's causing inflammation or blockage of the meibomian glands, we need to address those bugs and bacteria. E, enzymes. Esterases and lipases are released by bacteria in the lids, causing the formation of free fatty acids and saponification or the frothiness of the tears. I, inflammation. Well, we got that. We know that that's the hallmark of dry eye disease. S, stasis. That means like the thickening of the meibum, that toothpaste like or ketchup in a bottle that's stuck like aspect of meibum so that it can't have the fluidity that it needs to become the outer layer of the tears. T for temperature. Now, abnormal meibum melts at 35 degrees centigrade as opposed to normal meibum, which melts between 30 and 32 degrees centigrade. And obstruction. Obstruction could be from Demodex, could be from hyperkeratinization, it could be from the poor, thick, sludgy meibum. But all of those things together build the basis of meibomian gland dysfunction. And guess what? You don't need fancy equipment to address any of those things. Foundational care addresses them all. The TFOS-DO's Step 1 algorithm. Now, fortunately, we've got lots of options at our disposal when it comes to lid hygiene. We can recommend foam cleansers, we can recommend wipes, sprays, and even in-office procedures. And although we have a lot of options, as a profession, I don't think we've done a great job of educating our patients about daily lid hygiene and removal of the natural biofilm that forms on our eyelids. We really should take a page from our dental colleagues and talk about eye and eyelid maintenance products at home, just like dentists talk about brushing and flossing. We know that not all cleansers work the same way. Hypochlorous acid is a wonderful cleanser for bacterial-based blepharitis, but our CABIT studies showed us that it does not work at all for Demodex. So in a spray formula, hypochlorous acid is a wonderful way to get into all the little nooks and crannies for bacterial control. Cleansing wipes are great at removing debris because they have that little bit of exfoliative-like properties that can liberate that stuck-on debris on the lashes. On the other hand, tea tree oil-based cleansers are a great daily hygiene cleanser with efficacy for both bacterial and Demodex blepharitis, but at a lower concentration, probably better for daily hygiene than a true infestation or infection. And T4O-based cleansers, which are a subcomponent of tea tree oil with the most mitocidal property, great hygiene product for true infestations or infections, but it can also burn a little bit if it gets directly in the eye, so it requires a little bit more patient education for proper use. The upshot is we've got a lot of great options. We're probably just not using them as much as we should be. And finally, the very last aspect, using warm compresses, again, often overlooked. Despite years of research, eyelid warming is a poorly standardized treatment. Selecting a suitable eyelid warming mask could be very challenging because it's a very crowded market, and you can just Google on Amazon and you'll see hundreds of different masks there. And they're not necessarily all able to effectively meet the criteria necessary for lithiating. It's important that when we look for a hot compress, it has to hit the 40 degrees centigrade mark, and it has to sustain that temperature for the appropriate amount of time based on the patient's clinical presentation. For mild patients, 5 minutes, but for moderate to severe patients, 15 to 20 minutes. And many of those microwavable type masks won't sustain that 40 degrees Celsius for that full 15 minutes. So they may be great for the 5-minute mark for the mild patients, but we need to consider masks that can sustain the heat for more like 15 minutes or more for our more moderate to severe patients. Now, even though our emphasis tonight is on the foundations, I just wanted to show you this one study for those of you who are lucky enough to have IPL or RF. This is a relatively recent study published just last year. They looked at patients that were receiving IPL. Group 1 got IPL only. Group 2, IPL plus a heat mask for 20 minutes a day at home between sessions. And Group 3, no treatment. And essentially what we see when we look at the results of the study is that Group 2, the group that received an at-home hot compress in addition to IPL, had much better results than the group that got IPL only. Better statistically significant improvements in breakup time, lipid layer thickness, reductions in staining, and OSDI improvements. So although IPL alone is great, knowing that when we incorporate that at-home maintenance as well, we can get even better clinical results. All right, we're almost at the end here. Let's go ahead and apply this to a real case, and then we'll open it up to questions. You may have seen this case before. This was a fairly typical story. Police officer had LASIK 15 years ago. Dry eye symptoms started after LASIK. He's tried Restasis and Xiidra in tears. He's had no help. He's seen a lot of different doctors, and his LASIK doctor said, "Don't come back to me anymore. You're just complaining, and your results are perfect." When I took a look at him, basically, I started to realize that this was really affecting his life. He even said to me at one point, "Nobody's listening to me, and this has ruined my life." He also said that he couldn't see well, and he frequently had to blink to clear his vision, and he couldn't read license plates at a distance anymore. So on examination, he did have great refractive results post-LASIK, which is why the LASIK doctor was dismissing him. But he also had blepharitis, saponification of the tears, indicative of the bacterial enzymes reacting with the tear lipids. His dry eye testing revealed moderate to severe dry eye, high tear osmolarity, positive MMP9, reduced tear breakup time, practically non-existent meibum expression. Now, this patient isn't all that exciting or unique from a dry eye perspective. Any optometrist has the potential to make a big impact in this patient's life, regardless of the equipment that you have in your office. So what did I do? I started with TFOS-DUE's 2 algorithm. I educated about dry eye. I looked at environmental and systemic medication factors. We discussed how he had to make the vents on his patrol car point away from his face. We talked about turning the ceiling fan off at night. He did have preservative-free artificial tears, but if this were now, I might have used Mibo instead, but this is before Mibo was available. We put him on a 2,000 milligram a day high EPA formula, reesterified triglyceride form omega-3 fatty acid supplement. We put him on lid wipes twice a day and a microwavable mask daily. Now, up until this point, all I did was follow TFOS-DUE's exactly. This is the basic foundational therapy. Now, in this particular case, I did employ a TFOS-DUE's stage 2 tactic as well, and that was that I added Lotemax. And this is where a bit of psychology comes in, because although I didn't know if he really needed the Lotemax, I was pretty sure it'd be fine with just the foundational care. But psychologically, he was exasperated with all the dry eye stuff. So I piggybacked the Lotemax to get a faster result for him while we waited for the foundational care to work. And we're just about done here. He comes in 2 months later. He's feeling better, but I know what you're thinking. Of course, he feels better. He's on steroids. So now we remove the steroids, and let's find out if the stage 1 TFOS-DUE therapy works. And he comes back in, and yes, he's now largely asymptomatic, even without the steroid. His clinical symptoms and signs have improved, and this was a simple case. No investment in expensive equipment, not tons of office visits involved, but life-changing for this patient. And he's now sending in lots of other patients and singing our praises to his family and coworkers. And all we did was foundational TFOS-DUE's treatment. So let's remember, foundational dry eye management is available to each and every one of us, and it is in the best interest of our patient's ocular health. Remembering that education, tears, hygiene, omega-3s, warm compresses, it's the appropriate evidence-based medicine starting point for our dry eye patients.